Hello, and thank you for joining me. My name is David Pearson. I'm one of the bariatric surgeons at the Mayo Clinic in Arizona. Today, I'm going to share with you some general information regarding bariatric surgery, and I'm also going to try to answer a lot of the common questions that patients have when they're considering bariatric surgery as a part of their weight loss plan. I'm going to share some slides with you. At the Mayo Clinic in Arizona, we currently have three bariatric surgeons. My partners are Dr. James Madura and Dr. Christy Harold. And again, I'm David Pearson. And the three of us do the surgical operations for people who wish to have bariatric surgery. Obesity is a complex disease. There are a lot of factors that determine why some people carry more weight than others. Certainly, there are behavioral components and environmental components, but there are also genetic components. Two people that eat the same and exercise similarly will never be the same size and shape. And because there are a lot of factors that contribute to obesity, it's important that a solution to combat obesity addresses all of these different issues. And it's not so much the number of pounds that someone sees when they stand on the scale that's a problem. Rather, we know that as people gain more and more weight, they begin to develop a lot of major health problems. This is not a comprehensive list, but some of these include high blood pressure, sleep apnea, gastroesophageal reflux disease, joint disease, diabetes. There are at least 14 different cancers that are associated with obesity. We know that people who carry too much weight are much more likely to die a premature death and suffer from many other health consequences. And this is why we often treat obesity with surgery. Patients will often ask, well, who qualifies for surgery? In general, patients with a BMI of 40 or greater typically will qualify. BMI is a ratio of somebody's height and weight. And if you go online and plug in your height and weight into a BMI calculator, it will give you a number that is your BMI at this point. But roughly, a BMI of 40 correlates to approximately being 100 pounds overweight. For people whose BMI is not quite that high, in the 35 to 40 range, if you have at least two or more obesity-related medical issues, such as those I shared on the previous slide, um, you may also qualify for bariatric surgery. Some of these qualifying conditions are sleep apnea, diabetes, heart disease, and there are many others. At the Mayo Clinic in Arizona, we are very fortunate to have a very big team of providers that take care of our bariatric patients. We have bariatric trained nursing staff, psychologists who focus their practice on maladaptive eating behaviors and helping people with the psychological issues that accompany obesity. We have incredible nutritionists. We have, as I said, three bariatric surgeons. We provide a lot of patient education and we have a lot of bariatric equipment. We also recently we also recently got a new bariatric surgeon who is actually one of our transplant surgeons, and she works as a liaison between the bariatric program and the transplant program. And in the center of it all is our medical bariatricians. These are internal medicine doctors and endocrinologists who help to prepare our patients for surgery and help to take care of their medical problems as they go through the program and as they begin their life after bariatric surgery. And we're going to talk about a couple of operations that are commonly done. And these are operations that we do at the Mayo Clinic in Arizona. While many weight loss procedures have come and gone over time, the gastric bypass is one operation that has truly stood the test of time because of its safety and its ability to help people successfully achieve weight loss. On the left side of the screen, here is a normal stomach. When we eat, food comes down the esophagus and into the stomach and leaves the stomach and goes into the small intestine. When we perform gastric bypass surgery, the very top of the stomach is divided and it creates what we call a gastric pouch. This is often the size of a golf ball or a racquetball, but it's a very small volume pouch. So after or so when you eat, food comes down the esophagus and arrives in that pouch. In order for food to exit the pouch, we go downstream and divide the small intestine. One end comes up and is connected to that pouch, and the other end is plugged in a little bit downstream. What this results in is the fact that as food comes down and exits the pouch in the small intestine, it skips the vast majority of the stomach and it skips the very beginning of the small intestine. And this has major consequences on weight loss. First of all, when your stomach is the size of a racquetball, you feel full very quickly. Additionally, the part of the stomach that is skipped typically would produce a lot of hormones that communicate between your stomach and your brain that tell you you're hungry, keep eating. And when food no longer goes through that area, those signals between your stomach and your brain quiet down very significantly. And so appetite quiets down very significantly as well for most patients. This is another depiction of a gastric bypass. So again, here we have a stomach that's been divided and we have a small pouch. The surgeon will go downstream and divide the small intestine. One end will come up to the pouch and the other end gets plugged in a little bit downstream. Now, beyond that point, the vast majority of the small intestine is left alone, which leaves several hundred centimeters of intestine to allow for nutrients and food to be absorbed so that as you lose weight, you're still getting adequate nutrition and adequate vitamins in your diet. A sleeve gastrectomy, on the other hand, is a very different weight loss operation. This is also an operation that we perform at the Mayo Clinic in Arizona, but this operation doesn't involve the small intestine. Basically, this involves taking the stomach, which is under normal circumstances a large floppy reservoir for food, and turning it into a narrow, somewhat banana-shaped tube so that as food comes down, food arrives in this narrow stomach. This narrow stomach is not very stretchy. So as food arrives there, the stomach doesn't stretch out much and you feel full very quickly. And then food continues to progress through the sleeve and eventually into the small intestine. Now, a large portion of the stomach is completely stapled off and separated from the sleeve. This portion of the stomach is removed completely. It's taken out of the body, and once this is done, it cannot be put back. This portion of the stomach, as mentioned in the bypass, also produces a lot of hormones that affect appetite. So when someone has a sleeve, in addition to the volume of the stomach decreasing, those hormones that signal to your brain that stimulate your that tell your brain that you're hungry and increase your appetite, those hormones are decreased significantly after this operation. Therefore, appetite also goes down significantly after a sleeve gastrectomy. For the vast majority of our patients, we're able to accomplish these operations laparoscopically, meaning with just a few small incisions. Typically, people have soreness for about 2 weeks after surgery. As the soreness feels better, we encourage our patients to move and increase their physical activity as they fill up to it. The lap band is somewhat of a historic operation that is largely no longer performed in any great number in the United States. But it is an operation that was very common in the early 2000s. We include this picture in here because there are a lot of people out there who still have lap bands from the early 2000s who maybe didn't achieve their weight loss goal, or maybe now, years later, are suffering from some of the issues like reflux or difficulty swallowing. For these people, can often remove the lap band and often perform simultaneously a gastric bypass or other operation at that time. Patients always wonder, well, how do you compare a gastric bypass kind of side by side to the sleeve gastrectomy? There are some similarities, but there are certainly a lot of differences. Both of these operations result in significant weight loss over the first 12 to 18 months after surgery. The gastric bypass on average typically results in people losing about 60 to 70% of the extra weight that they carry. So for a person who's approximately 100 pounds overweight, we would expect the average person in that situation to lose 60 to 70 pounds in about a year to a year and a half. The sleeve gastrectomy also has good weight loss, albeit it often has slightly less weight loss. And that's about 50 to 60% of the extra weight that people carry on average. So it's a little bit less. Both of these procedures are invasive operations, And so, because of that, there can be complications which can be serious. The complications of these operations, however, are very similar. For example, there's about a 1% risk of bleeding with these operations. There's about a 1% risk of infection and a 1% risk of leaks from the staple lines or the connections that we make in the case of the gastric bypass. Now, both of these operations affect the speed at which food passes through the stomach and the beginning of the small intestine. And because of that, vitamin deficiencies are possible. In order to prevent this, all patients that undergo gastric bypass surgery or sleeve gastrectomy surgery should take multivitamins for life. Our dietitians recommend that our patients take a multivitamin with iron, some calcium, some vitamin D, and some B12. And we know that if patients take these multivitamins every day forever after surgery, the risk of vitamin deficiencies is exceedingly unlikely. Now, both of these operations at current time, typically we have our patients stay overnight in the hospital. The day after surgery, as long as their vital signs are acceptable and as long as they're drinking well enough to stay hydrated, typically we'll be able to let them go home. A gastric bypass is an operation that technically can be reversed, although it's a big operation to reverse a gastric bypass. A sleeve gastrectomy, on the other hand, is not reversible. The portion of the stomach that is removed permanently and can't be replaced. One big difference that exists between the bypass and the sleeve is this issue of acid reflux. Current evidence shows us that up to two-thirds of people that have a sleeve gastrectomy may develop new or worsened acid reflux. So if acid reflux is a prominent problem that patients have, a sleeve gastrectomy may worsen this, and all patients should be aware of this. A gastric bypass, on the other hand, is a very effective operation in curing acid reflux. Approximately 95% of people who have a gastric bypass no longer experience reflux after surgery. So that's a major difference between these two operations. Recovery after surgery, as I said, typically requires a one-night stay in the hospital. Most patients experience abdominal soreness for about 2 weeks after surgery, but the bigger part of the recovery really is adjustment to life with a small stomach. You should ask your surgeon about any surgeon-specific activity restrictions that they may have after surgery. But most surgeons will recommend that as your pain gets better, you gradually increase your physical activity, and once you're pain-free, that you start slowly with physical exercise, and that if you develop new or worsening pain at any of your incision sites, that you stop that physical activity until that pain resolves. Moving forward, our office will reach out to each one of you to offer you an appointment to come into one of our bariatric intake clinics, if they haven't already done so. Typically, we have 8 classes that are administered by Zoom that help prepare people for life after surgery and answer a lot of the common questions about diet and activity and how to be successful after bariatric surgery. Some insurance companies or insurance plans will have specific requirements, such as a waiting period where you have to be in the bariatric program for a defined period of time. Our financial department can give you instructions as to what your insurance plan specifically requires for you in order for your insurance company to pay for your bariatric surgery. Typically, from the time that people begin the program, it's about 3 months at the soonest before they actually get to the day of surgery. I hope that this has been useful and helpful for you, and I hope you've been able to learn a lot of good information regarding bariatric surgery. And I hope that someday we'll be able to meet with you in one of our upcoming bariatric information sessions. Thank you so much for joining.